Welcome and thank you for joining us today for the Body Composition and Treatment Related Toxicities webinar. My name is Vanessa and I will be your WebEx technical support host. Before we dive into today's meeting, I wanted to provide some technical background on WebEx. All lines have been muted and will remain muted for the duration of the webinar. Please submit questions throughout the presentation using the chat and select all panelists. A moderator will ask the comments and/or questions on your behalf at the end of the presentation. If you require technical assistance, please feel free to contact me, the host, via the chat panel, and I'll be happy to assist you. If you need closed captioning, please refer to the link in the chat panel. We also wanted to make you aware that today's webinar is being recorded. And now I'll turn it over to Dr. Joanne Elena to introduce our speaker.
Thank you, Vanessa. We are in for a treat today. Our speaker is Dr. Michael Sawyer, a professor in the Department of Oncology of the University of Alberta and a medical oncologist and clinical pharmacologist for the Cross Cancer Center of Alberta Health Services. He obtained his Bachelor of Science in Pharmacy and his medical degree from the University of Toronto. He completed his Med-Onc Fellowship at the University of Western Ontario and completed his training in drug development and clinical pharmacology at the University of Chicago Cancer Center. I first became aware of his work through some of his collaborations with Dr. Vicky Barricos and Carla Prado, and combining the fields of body composition and cancer chemotherapy. A major focus of his work now is how differences in lean body mass contributes to differences in toxicity experienced by individual patients. So obviously the body composition piece runs deep in this, and I'm really looking forward to hearing some of this, hearing his new work today. The major focus of his research program is TKI pharmacology as it relates to therapy and toxicities. He's written more than 130 articles on cancer biology and chemotherapy and given over 70 presentations. I feel like we've all given about 70 presentations a day lately in this quarantine period, but we are very fortunate today, and I'm looking forward to this talk. So join me in welcoming Dr. Sawyer, please.
All right. Thank you, Joanne, for your kind introduction, and thank you for inviting me to give this talk today. So, my disclosures, as a clinical pharmacologist and medical oncologist, I think it might be easier to list the drug companies that I have not been involved with in terms of honoraria or consulting or doing clinical trials with. That being said, this is essentially non-commercial work. I wish in some ways it was more commercial. And I will start back at the very beginning in the 2000s when this work on body composition and imaging in general was starting, particularly at Columbia University, and a good friend of mine became aware of this and started to learn about this technique. How the work in drug toxicities and body composition came about was that good friend and my very good colleague, Dr. Vicky Barricos, back around 2004 and 2005, learned how to use Slice-O-Matic like possibly nobody else on the planet. At the same time, a young Brazilian dietitian landed on our doorstep and wanted to do her PhD, and was starting work with Vicky. And Vicky and I sat on the ethics board of the Alberta Cancer Board. And so Vicky sent Carla to me and said, I have this new imaging technique. Have you any thoughts on how we might be able to apply this in medical oncology? And from my fellowship training, I was actually very much primed to consider this question. And I will politely thank the NIH for allowing me in through the back door with my own funding to participate, actually, in an NIH-sponsored clinical pharmacology program at the University of Chicago. And while there, I wrote a paper with my mentor and supervisor, Dr. Mark Ratain, on body surface area as a determinant of pharmacokinetics and drug dosing. And this is actually a fairly well-quoted paper in clinical pharmacology and medical oncology circles, because it basically nicely summarizes that basically body surface area does not do anything of what we think it does in terms of decreasing interpatient variability and reducing toxicity. Basically, body surface area doesn't do anything in terms of normalizing pharmacokinetic principles. And I had gone through a lot of papers to write this review. And this little table actually summarizes some of the more salient points and why when Carla came to me and said, we can measure lean body mass, my answer was, lean body mass? You can actually measure this easily? And what this shows is body surface area has good relationships to liver volume, kidney volume, blood volume, as does body weight, but in no way, shape, or form does it actually do much in terms of a relationship to liver function. In fact, when they did a study looking at antipyrine clearance, which is almost exclusively by the liver, there was no relationship whatsoever between the clearance of antipyrine and body surface area or body weight. But in fact, lean body mass, there was a relationship. The same thing for kidney function and blood volume. So when Carla came and said, Vicki has this wonderful technique and tool to measure lean body mass, can you help me think of a research project to do this? Several things came to mind, particularly this paper. And then they showed me examples like this. And as a medical oncologist, I plead guilty to one horrible thing here. As a medical oncologist, when I previously looked at CT scans, I looked at things that weren't supposed to be there, the spots on the liver, the swollen lymph nodes, and hoped to see them get smaller. I actually never bothered to notice the things that were supposed to be there that were disappearing and shrinking. And the case on my right and your right is a perfectly normal person. The person on the left has the same body surface area, the same BMI, but both Vicki and I actually wonder how this person actually was still alive given how little muscle was underneath it all. And with current chemotherapy dosing paradigms, either body surface area or flat dosing, each of these people will get the exact same dose. Later on, I became aware of something that most simply could be described as muscle quality, or more colloquially, marbling of the muscle. And again, each of these people from the outside would actually look the same. They have this almost identical body mass index. They have the same amount of muscle, but the nature of the muscle is completely different. And this slide also comes from later, but shows also another very important point. As I said, body surface area very poorly reflects what goes on underneath. Now, in Canada, like elsewhere, the body mass index has drifted up, and therefore body surface area has drifted up. But at the median body surface area in these otherwise well, healthy, adjuvant, apparently cured breast cancer patients, at approximately a body surface area of 1.78, their lean body mass goes from 35.5 to 50. And what Carla, Vicki, and I showed in a paper where this diagram comes from is that 30% of the variability of epirubicin could be attributed to lean body mass. And right at this point, every one of these people would get the exact same dose. There was some theoretical hypothesis underlying the original work, at least in my mind, as a clinical pharmacologist, pharmacist, and modest pharmacokineticist. I could actually see two ways that body composition could affect pharmacokinetics: volume of distribution, and as a measure and marker of inflammation, which would have an effect on drug metabolism. The easiest one to think about in some ways is the volume of distribution. As a medical oncologist and a cousin to hematology, we often think of blood as being one of the largest organs in the body, being around 5 to 6 kilos. But in actual fact, probably the king of the hill is actually muscle. And that is a very large volume, a very large protein mass, and a very large volume of water. As well, our first paper was actually fundamentally based on certain assumptions. Ideally, to do this, one would actually look at the pharmacokinetics, the volume of distribution, and clearance. But that is very hard to get one's hands on at times. So I used a parallel method, an analogy, in that people with low clearance, possibly low volume of distribution, would have increased toxicity. Corollaries also to that is that body composition could also affect progression-free survival and overall survival. In some ways, thankfully, we started with one drug, and one drug is much easier to deal with in that there is only one relationship to look at. And as I mentioned, in an ideal circumstance, lean body mass and fat mass would be looked at with clearance, but barring that, looking at toxicity and efficacy would be a reasonable follow-through. Much more challenging, even to a pharmacist and clinical pharmacologist, is when one gets into multi-agent regimens. In that, not uncommonly, you could have a drug that may be very hydrophilic mixed in with a drug that is very hydrophobic, one that is highly protein-bound, one that is not protein-bound. And frequently, many chemotherapy drugs have overlapping toxicities such as neutropenia, anemia, fatigue, and diarrhea. So multi-agent regimens, unless one is focusing particularly on the pharmacokinetics, can be quite challenging. How I think one can overcome that is if there is a unique toxicity to one particular drug. And I will show you that in terms of oxaliplatin. The other one we have done, particularly in lung cancer, is carboplatin and thrombocytopenia. One approach as well that gives away who is thinking about the drugs and how they were thinking about the drugs is it can be difficult to characterize the toxicities in terms of grade in doing chart reviews. I know this full well from being a medical student and doing my own chart reviews and from seeing other people's chart reviews. I actually prefer to actually go from pharmacy records and use a concept called dose-limiting toxicity. And dose-limiting toxicity to a phase 1 clinical pharmacologist means whatever that toxicity was or is, I have to reduce the dose or delay, or the patient just decides that they've had enough of it and they do not want to have any more. I have seen some challenges as this field evolves, and sometimes I think these studies that I've reviewed would have benefited as much from having a clinical pharmacologist involved as a statistician, in that I have seen alphabet soup of drug regimens and things combined that to a clinical pharmacologist, I couldn't wrap my head around if I spent a month. I have seen occasionally where taxanes have been combined, multiple taxanes. And what I've shown here on this slide is if the fundamental assumption of how a drug is causing toxicity is by an alteration of its pharmacokinetics, mixing docetaxel, which has a volume of distribution of 113 liters in its apparent volume of distribution, with a series of patients with nab-paclitaxel, which has more than 10-fold its apparent volume of distribution, I cannot pharmacokinetically actually wrap my head around. As well, although nab-paclitaxel has extreme protein liposome binding, its natural volume of distribution actually almost perfectly mimics the plasma volume, which is 6 liters. So, as I said, I have seen some challenging contortions in terms of pharmacology and pharmacokinetics. So, fortunately, way back in 2005, 2006, I had completed an adjuvant study of colorectal cancer patients, looking at the effects of imidylate synthase polymorphisms on 5-FU toxicity. It completely fell apart in terms of finding any relationship whatsoever. But around 2005, 2006 is when Carla showed up on my doorstep in my office. And we had 102 patients who all had immaculately collected toxicity and dosing data. Now, at that time, we did not routinely CT scan everybody, but we did scan 62 of those people. And we were able to lay our hands on those CT scans. And not unexpectedly to any GI medical oncologist or medical oncologist in general, when you looked at the toxicity data, the majority of the toxicity was in the women. And this is almost carved in stone and carved in granite in medical oncology, that women always tolerate 5-FU more poorly than do men. And I would say, and this is a strong hint, that up until 2007, there had been no good explanation as to why women more poorly tolerated 5-FU compared to men. We looked at the dose of 5-FU per kilo of lean soft tissue using a formula done by Dr. Maracas, who is also a PhD student of Vicky's. And although everybody was dosed at the standard 425 milligrams per meter squared of the Mayo adjuvant regimen, when you actually looked at it per lean soft tissue, we saw almost a 300% range in the dose per lean soft tissue, going from as low as 12 to 33 milligrams. And we found a significant difference between those patients who did have dose-limiting toxicity versus those who did not. That was relatively small, but when we did actually a cutoff to find out the dose of 5-FU, we found that at approximately 20 milligrams per kilogram, there was a severe risk of developing 5-FU related toxicity. And the gender split on that cutoff was very interesting. Only 2 men out of the 62, and this was a predominantly male cohort because males get at an increased risk colon cancer compared to women. 13 women went over 20 milligrams per kilogram. And of those 2 men, 1 out of 2 had dose-limiting toxicity, and 11 out of 13 of the women did. And needless to say, the amount of 5-FU per body surface area was absolutely not different between the 2 groups. And I would suggest that the difference possibly between lean body mass between men and women based on this study may play a major role in the differential toxicity of 5-FU between men and women. After we did that first paper, I literally said to Carla, well, that's interesting, but God only knows, maybe this is just a fluke. On the other hand, I had also initiated at the same time a pharmacogenetic study of capecitabine in breast cancer patients. Needless to say, all of these patients, though actually I think in the true study, which was 102, there was the odd male, but in actual fact, not surprisingly, when the dust all settled and we were able to get CT scans, we had 55 female patients. 26% of them were sarcopenic, 74% of them were not sarcopenic. The rate of dose-limiting toxicities was 50% in the sarcopenic versus only 20% in the non-sarcopenic, with a hazard ratio of 4.1. Now, thankfully, Dr. Sami Antoine in the late 2000s actually brought over a entire CT scan set from the registration study of Nexavar in kidney cancer patients. Now, the reason that he brought it over was that the responding patients actually lost weight, and that was the primary purpose of our looking at them, was to figure out what was the nature of the weight loss. But we also looked at it to examine if there was any relationship with body composition and toxicities. So even with TKIs, we found a significant relationship between body composition and dose-limiting toxicities. The open white triangles are dose-limiting toxicities. The square boxes are patients who did not experience dose-limiting toxicity. The patients who had a normal to low body mass index and below a cutoff in terms of the muscle mass index had a toxicity rate of around 70% versus in the high teens in the large patients with a large lean body mass. And Dr. Francois Goldwasser's group followed up our work and actually looked at the pharmacokinetics of sorafenib in hepatocellular carcinoma patients. And they looked at all of the HCC patients they treated from June 2007 to December 2010. And those patients were either treated at 200 milligrams or 400 milligrams twice a day, according to their attending physician's belief on how much they would tolerate it. As well, they also performed a pharmacokinetic study starting in around October 2008, which overlapped with many of these patients. They assessed the toxicity on days 14 and 28 in cycle 1, and borrowing from our definition of toxicity, it was a dose reduction, treatment delay, or discontinuation. And to a certain extent, although everybody was flat dosed, relatively speaking, they saw a sorafenib dose per kilo of lean body mass on the range of fourfold, 400%, ranging from 3.8 to 16.8. Again, in a different cancer, but the same drug, the sarcopenic patients had a markedly increased rate of toxicity, and that was particularly in terms of the diarrhea and not so much in the hand and foot. And there was a very strong trend in terms of the sarcopenic patients having a higher area under the concentration curve, suggesting that indeed the body composition was linked to the pharmacokinetics, which was then again linked to the toxicity. More recently, we actually looked at the role of body composition in the neuropathy and tolerance of FOLFOX chemotherapy in colon cancer patients in collaboration with France. And this shows some of the techniques that I have used in dealing with these multi-agent regimens. We took 2 prospective studies that were done in France and combined that with retrospective data of patients treated with FOLFOX at my institution in Edmonton, Alberta. This is essentially the Table 1 patient demographics, and it shows in the clinical study what I hinted at was the case with 5-FU alone. Women were more likely to get mucositis or diarrhea than men, and more likely to get neuropathy than men. And this shows the challenge of doing this retrospectively, in that the retrospective data actually shows the reverse. And I always am more suspicious about toxicity data gathered retrospectively. But we focused on the oxaliplatin neuropathy particularly because that was a unique toxicity to oxaliplatin and could be differentiated out. And when we looked at that, we found a very clear cut point of 3.09 milligrams of oxaliplatin per kilogram of lean body mass, which was highly statistically significant. I think, memory serves me right, the p-value was less than 0.001. with 40% of patients above that getting dose-limiting toxicity versus none below that. I have now extended this on partially as a GI medical oncologist and amateur nutritionist. Over the years, I consider pancreatic cancer to be essentially the king of cancer cachexia. And I was actually presented with a bit of a problem, and I was actually presented with this problem from my pharmacy department, in that gemcitabine and nab-paclitaxel appeared to be one of the best regimens to treat pancreatic cancer. That being said, this study was done in the United States and on a clinical trial to a great extent, and they very liberally used G-CSF and Neulasta. And as we politely refer to ourselves as a health technology assessment country, we were not able to use G-CSF routinely in metastatic cancer patients. So my pharmacy department asked me to whip up a new dosing schedule for gemcitabine and nab-paclitaxel that did not involve G-CSF. And subsequently, when Celgene became aware that we actually had a dosing regimen that was uniform across the province that everybody seemed to love, they wanted to borrow it for the rest of Canada and the rest of the health technology assessment countries. And I was successful in convincing them that I would actually like to prove that this dosing regimen worked both in terms of toxicity and in efficacy. And they agreed to that. So we actually managed to get all the toxicity data and dosing records from our electronic medical records for 81 patients, essentially all of the patients treated in Alberta from 2014 to 2017. And we actually had CT scans on those within the 30 to 60 days that we usually like, but only for 152. And I will speak highly of my former profession and current profession, somewhat, in that pharmacy students are a tremendous resource for actually compiling dosing and toxicity records. And I had a general surgery resident currently doing her master's with me in terms of body composition and melanoma, and she gratefully analyzed this. And when you look at it, there were slightly more male patients in this. There were a lot of ECOG-2 patients and maybe some ECOG-3s that were called ECOG-2s. Oops, got ahead of myself. Interestingly, when you actually looked at the dose-limiting toxicities, even without starting to do significant statistics, their skeletal muscle index was much lower and statistically significant in the patients with dose-limiting toxicity. As well, the dose of NAB per kilo of lean body mass almost made it, and it showed a very strong trend. We were actually able to do, though this was somewhat liberally, a cut point analysis on this, and showed that exceeding 5.83 milligrams per kilogram of nab-paclitaxel was significantly related to the neuropathy of gemcitabine and nab-paclitaxel, and the dose-limiting toxicity of the entire regimen. Why this is interesting is because of this slide. These are the overall survival of patients depending upon whether or not they develop neuropathy. The red line are the patients that did develop neuropathy. The blue line is not. Which you could start to argue means that these patients who were not at significant risk of developing the toxicity were also at significant risk of not developing the efficacy as well. We actually tried to look at that. There was a very strong trend into the high teens, but I think part of the problem here was we lost about 30 CT scans from looking overall at dosing and toxicity without the CT scans to looking at dosing toxicity with the CT scans. One of the strongest areas of interest in medical oncology particular and hematology, but in general, is in personalized medicine. And there is much talk about genomic testing, next generation sequencing, trying to find actionable mutations in a tumor, looking at biomarkers such as PD-1 and HER2 to try to select the right drug for a particular patient, pharmacogenomics, thinking about patients who are deficient in activating enzymes. A classic example in medical oncology is cytochrome P452D6 and tamoxifen. And from a toxicology perspective, cytochrome P452D6 and beta blockers, or UGT1A1 and irinotecan. But having gone through all of these studies that we had done and the rationale for them, have we got the dose right? Have we got the dose right for many of these drugs? I forgot to point out that the vast majority of those patients who had dose-limiting toxicity in the data set that Sammy brought over from Sawyer from the Institut Gustave Roussy never restarted sorafenib. They were that impacted by the toxicities they could not be convinced to go back. And I believe it. I truly question, makes my day job slightly challenging, whether body surface area dosing is correct whatsoever, whether flat dosing is correct whatsoever. I gave a talk at the Chinese Society of Clinical Oncology many years ago, and I had one of their premier basketball players, whose name is escaping me, standing beside Prince William. And captioned above it, basically both of these people would get the exact same dose in any flat dose chemotherapy drug. We have known for decades, probably going back actually almost half a century now, that the fluoropyrimidines are more poorly tolerated in women. The secret to this may actually have been staring us in the face all the way along. People have thought that it's maybe the cancers that are causing the differential toxicities of the different genders. But if you think about capecitabine, as a GI medical oncologist, I routinely use 1,250 milligrams per meter squared without blinking or batting an eye. But most GI cancers have a predominance of men. On the other hand, when those doses were translated into the treatment of breast cancer patients, my colleagues in medical oncology who treat breast cancer found the 1,250 milligram per meter squared, which is standard of care in GI, to be utterly intolerable, and found that they had to dose reduce almost everybody. And they soon came to the conclusion that no, we do not use 1250, we use 1,000 milligrams per meter squared. I would very much suggest to you that what medical oncologists, I included in that, are seeing in our day-to-day practice is nothing more than a reflection of the differential lean body characteristics between men and women. Geriatric medical oncology is a significant area of interest. I truly think that lean body mass is rearing its head, in this case, all the time. I frequently have treated geriatrics, 80, even 90-year-olds, and have actually done it safely, but I have eyeballed their CAT scans and done some rough calculation in my head at how much or little lean body mass that they have had. And where I often see this also rear its head is when my colleagues call me up and tell me that a little old lady, the computer has just said, needs 800 milligrams of carboplatin, a dose that they are quite certain will absolutely flatten them. And they are calling me to ask me what I think is the correct dose. And this also gets to what we have fundamentally acknowledged forever in medical oncology, that poor performance status patients are at increased risk of toxicities. What I truly think would be the next outstanding step to take in this setting are really pharmacokinetic studies of drugs going forward and of existing drugs, and doing concurrent CT scan analysis and using the excellent toxicity data that is already collected from these, which I know full well, painfully full well, as a phase 1 clinical pharmacologist, and to prospectively examine the dosing in terms of drug per lean body mass, per muscle surface area, validate it, and then go forward with validating that dosing regimen. I am certain and hopeful that an approach like that would have significant impacts in the quality of life, tolerance of our cancer patients in general, and truly would be one of the greatest examples of personalized medicine. I have more than a few people and institutions to thank. First and foremost, Dr. Vicki Barakos, who I've been joined at the hip with throughout this rather interesting and incredible journey. Dr. Carla Parado, who we both co-supervised way back when she was doing her PhD. Dr. Sammy Antoine, Lisa Martin, my own residents and trainees, Michael Chu, Jessica Hopkins, Susie Yoon, and Mrs. Carol Chambers, the head of the pharmacy department in the Alberta Health Services, who has given me liberal opportunity to borrow from the electronic health records of the pharmacy department. And in terms of funding and support, the Alberta Cancer Foundation, particularly the estates of Pamela Miles and John McRae, Bristol Myers Squibb, Celgene, Alberta Innovates Health Solution, Alberta Health Services, the Alberta Cancer Board, and most definitely not least, the Alberta Cancer Registry, who Vicki and I have leaned on heavily over the years, and is actually somewhat part of the SEER collaboration of the NCI. Thank you very much for your time and attention. I'm ready.
Thank you. That was fantastic. Really interesting. And I'm going to start with questions. I've heard from a few people that the Q&A section isn't working for them. So feel free to put it into the chat as well. That has been working for some other folks as well. I'll start with a question. Getting to that. There we go. Okay, from Vicky. What would you predict to be the outcome if a phase 1 investigation were to be done in sarcopenic patients separately from muscular patients?
I would expect that we would actually find a lower dose would be tolerated. And speaking, I feel like I'm actually a freak of nature as a pharmacist, physician, clinical pharmacologist, and courtesy of Vicky, a amateur nutritionist. If you think about what happens in medical oncology, we administer these drugs in very advanced cancer patients. That's where all phase 1 studies are done. We are determining the dose of the tolerable dose of these drugs in patients who are some of the most sarcopenic, battered, and beaten up cancer patients that we have. Then we say this is the tolerable dose. And historically, people have been like, okay, this got through barely well in these very sick people. Now we're going to take it to phase 2, phase 3, and into standard of care. And what you find as you go up is that it's better and better tolerated, because all of those patients in the phase 3 study are less sick, less advanced, and practically speaking, our standard of care doses that are derived from phase 1 may ultimately be too low for the real world, and we may not actually be getting the most bang for our buck.
Well, so from Alicia Beagle Deal, sorry, I think I butchered your name. You said it was a higher average dose in patients who are presenting toxicities. Shouldn't it be a lower dose?
Yes. Well, when we give the standard dose to these people based on body surface area, flat dosing, we're not taking into account their body composition in general. The vast majority of medical oncologists, though in all fairness to them, the vast majority of medical oncologists have not seen the slideshow that I have just shown you. So when you think back to that wolf in sheep's clothing slide that I showed you, where the outside is the same on both of those people, they are going to get exactly the same dose of chemotherapy, whether it's body surface area or flat dosing. But when you compare it to the lean body mass, the person on the left who has a layer of fat overlaying what would appear to be a survivor of a Holocaust concentration camp, they are going to get a massive dose of the drug. So to answer that question, I think, yes, they actually should get a lower dose if one took into account their body composition. But unfortunately, in the real world, they're getting the max dose. And
are there resources that you would recommend to find the toxicity data in terms of drug amount for cancer patients?
To find the toxicity data, I think the hardest toxicity data actually comes from pharmacy dispensing records, particularly the cycle 2 dose. And I have been blessed partially because my pharmacy colleagues consider me somewhat of a lost stranger, gone over to the dark side, or however else it has been put to me over the years. and have freely allowed me to get access to the pharmacy record. Speaking as a physician who has done chart reviews himself or had medical students do chart reviews under me, it can be very difficult to determine the grade of toxicity. That being said, though, if you see that the medical oncologist has dose reduced the drug from cycle 1 to cycle 2, that is a significant toxicity. That, however, these toxicities have summated 1 or 2, 1, that medical oncologist was convinced that he cannot use that exact same dose to come back and treat that patient.
So I have a question from Candy Velasquez. Thank you for presenting your great work. I'm a preclinical researcher. In my animal studies, I usually dose using lean mass from DEXA. Do you think I should be using lean mass from CT scan instead of DEXA in these preclinical studies? And there was a similar question asking for you to mention how you're assessing lean body weight.
So I think DEXA, particularly a small animal DEXA, would be every bit as good as a CT scan. And in fact, it's probably set up that way. The beauty, how we had done all of our assessments are using the abdominal CT scans and focusing on the L3 to L4 vertebrae. If you actually go back to Shen's original work, the correlation coefficient at L3 was at its maximal, but at L4 and L5, it was still very good. And pragmatically, clinically, we occasionally get challenged by hardware causing spray artifacts and not being able to see at L3. And in that case, we use L4 to L5. But I think in preclinical models, DEXA scan would be perfectly fine. And in fact, I wish actually more preclinical experiments and the IB brochures actually considered that. It is standard in any investigator brochure that every clinical 1 pharmacologist is clinical phase 1 pharmacologist is presented with the body distribution studies that are done in animals. But nobody seems to actually use them in the real world going forward. And I have jokingly said I would kill 10,000 rats 10 times over to save one kid's life in leukemia if it was an experiment. So I am totally not anti-animal experiments. We would not be where we are, or not maybe get where we need to go without them. But it's so disappointing to me that we have not used that data that is collected to its fullest.
The next question is from Neely Ulrich, and asking about what you've seen by sex. Sorry, my screen just went down. Okay. With lean body mass tracking so closely with sex, I'm wondering whether you have observed similar effects within men and within women, and also whether or not your analyses are adjusted for sex.
We have not adjusted them for sex. In actual fact, I think if you look at lean body mass, and you will find gender disappear. This is almost Washington. On the basis of sex, it falls out once you consider lean body mass. I could actually possibly talk for several hours, and as I discussed with you, Joanne, as we were setting it up, I precede this talk down. I have done some interesting analysis, and I am quite convinced that a lot of the gender differences actually go poof when you start considering for lean body mass.
From Kirsten Bell, can you comment on the impact of fat mass on treatment toxicity? In particular, I'm wondering whether sarcopenic obese patients fare better or worse than sarcopenic lean patients with respect to treatment toxicity.
That is $1 million question. And my intuition is that sarcopenic obese patients potentially are at grave jeopardy in some ways, and also and potential efficacy. If you are dealing with a drug, and this may be totally what is happening with women and 5-FU and capecitabine, that is essentially hanging out in lean soft tissue compartments, and you are dosing them by body surface area, those people, if you do not cap them, will get a massive dose of drug. And if underneath all of that, there happens to be a low lean body mass, oh boy. That is probably the cause of a lot of the toxicity in women, particularly.
Yes, you mentioned, oh, this is from Merit Malinek. You mentioned several metrics, kidney and liver function, for example, that were more strongly correlated with lean body mass than BSA or BMI. Have you looked at whether markers of inflammation more strongly correlate with lean body mass versus overall adiposity?
Not in terms of overall adiposity, but to step back a bit, there is pretty good evidence to suggest that CRP lymphocyte neutrophil ratios are correlated with myosteatosis. And when Vicki started showing me her new work on myosteatosis, my gut intuition was that this was inflammation. And I actually look, and what I tried to convey in this talk is, to a certain extent, to me, as a clinical pharmacologist, pharmacokineticist, these aren't just numbers. They're actually reflecting pharmacokinetic compartments and processes. So I think of sarcopenia to a great extent reflecting protein binding, volume of distribution, and potentially clearance in some ways, because what not everybody thinks of is that clearance can actually be dissolving into a volume of distribution. And I tend to think of myosteatosis as reflecting overall inflammation, and there is a very minority opinion in medical oncology that actually believes that inflammation, by downregulating cytochrome P450 and protein metabolism, can impact drug metabolism. So
we are at the hour, and I have 2 pages of questions to go. So I'm going to, everyone, please feel free to log off as your time permits. We have another webinar on March 11th. Dr. Marcus da Silva Goncalves, and I put the registration link in the chat feature, but I am going to ask Dr. Sawyer 1 or 2 more questions, if you wouldn't mind. And
totally.
I will send you the list of questions and you can respond to folks. I think some of these may be questions that pique your interest.
I've seen some of them, and they're actually quite good. As I said, I was just limited in what I could say, but I have been dabbling in therapy as well,
okay,
as you.
Thank you. So have you, this is from Dan Hurt, have you conducted or proposed a crossover study with BSA and lean body mass to show a reduction in PK variability?
No, I would love to. I think those are absolutely the studies that need to be done. Maybe hard to do a crossover, particularly if you're dealing with toxicity and you run into somebody along those lines. But
oh, sorry. Oh, this is a question I have actually as well. Does toxicity equate to successful treatment of the cancer process? Or do these patients quit treatment due to lack of tolerance, resulting in higher recurrence mortality? And I wanted to add my piece is we're looking at the effects, but what about survival in patients? Looking at the other side of the coin, making sure people with a good muscle mass aren't underdosed.
That is a mouthful. That is a long question to answer, and I will try to remember to answer all parts of it. If I forget part, please remind me. I do believe that efficacy is related to toxicity. And in actual fact, one of my favorite clinical pharmacologists that goes back 20 to 30 years, and you can find this paper, it's by Howard Gurney. He's a medical oncologist out of Australia. And I'm blanking on the precise title, but it was essentially his magnus opus on chemotherapy dosing. And what he criticized us for as a subspecialty profession, med hem onc, was we will lower the dose of drugs for toxicity, but we never escalate the dose of drugs for the lack of toxicity. And there is only one regimen that actually even remotely, that does consider that, and nobody actually reads the fine print to actually do that. And that is FOLFIRI and or FOLFOX. If you read the tiny fine print in the study, it says start at 2,800 milligrams per meter squared of 5-FU, and if that does not cause any significant toxicity in cycle 1, escalate to 3,200. And that is why I brought that last study up, which is so tantalizing close. It is in one analysis of these pancreatic cancer patients, neuropathy predicted survival. In a smaller subset of that, we were able to show that the amount of nab-paclitaxel that they got predicted their neuropathy. Fuse those two concepts together, and it would suggest that you need to dose the people to neuropathy to get this best survival advantage in pancreatic cancer patients. And if you really think out of the box, what that actually means is if you think that poor performance status patients have the lowest lean body mass and are also a little bit the most fragile, that means that if you go in and treat those people, the people who are actually doing the worst to start treatment actually will do the best with the treatment. So I do think, if I've answered all of that very almost a thesis unto itself question, that efficacy and toxicity can be linked. Not all the time. And it also gets to another point as a medical oncologist. The challenge is that I'm trying to save people's lives, get them to a granddaughter's birthday, an anniversary, without making them sick. I would think that some people would benefit from getting more of the drug and not get sick and get more efficacy. And we may also actually improve at the other end, not making some people so sick that they stop the drug before we get a chance to see improvement, or if there's something else, and there may be something else that prevents the cancer from responding, not making them sick in between. It's somewhat, and I'm blanking on his name, it's a joke about stage migration and the people moving from Arizona to California and the idea of both
Will Rogers.
Yes, Will Rogers phenomenon applied to dosing. Essentially, we will actually improve both ends of the spectrum's outcomes not overdosing those who are and increasing and more precisely dosing those who could tolerate.
Well, I think that's a great place to leave this. I will, for those of you who have burning questions, I hope it's okay if I offer them to email you, and I will send you these questions. Thank you, Dr. Sawyer. We look forward to seeing everyone again back next month. Thank you so much, and I'll see you in March. Thank you.